Hi everybody and welcome to the inaugural TiCME Chat. I am absolutely delighted to have with me Dr David Lamond. David Lamond is the Deputy Director of the Capital Region Retrieval Service, a Senior Specialist in Emergency Medicine and a great mate of mine, and we get up to all sorts of adventures outside of work. David, thank you so much for coming along.
Oh, it's great to be here, Nick.
Today we're going to talk about a very interesting topic, and I know one that Dave's an expert in hypotension and trauma. Okay mate, so unfortunately a all too familiar scene for you here.
Yeah, this is a high-speed motor vehicle accident on a rural road. You can see the two cars have collided in bad weather, unfortunately involving young patients in both cars, and we've got a 21-year-old male who's trapped by confinement and who's severely injured.
So there's a 21-year-old male from this crash. You're loading him into the back of the helicopter and his blood pressure is 90 systolic. What does that mean?
Well, to me, that means that this patient is in severe trouble, that this is end-stage shock. For most people, though, we tend to think that BP 90 is the targeted blood pressure for hypotensive resuscitation. But I guess what I want to talk to you about today is I really think that we're missing the boat in these patients.
Great. Righto, Dave. So pre-hospital guidelines in a lot of places tell you to resuscitate trauma patients to presence of radial pulse. What blood pressure does a radial pulse indicate?
Yeah, well, ATLS folklore has it that if you've got a radial pulse present, then the systolic blood pressure is more than 80. It's said that when the radial pulse disappears and you've got carotid and femoral pulses present, that the systolic blood pressure is 70, and if you've got carotid pulse palpable only, that the blood pressure is 60. Is
there any evidence for this?
No, I mean, like I said, it's folklore. And
okay. Well, the first study you want to talk about, Dave, is Deacon and Lowe's.
Yeah, so this is published in BMJ in 2000. What they looked at was sequential patients that had hypertension secondary to hypovolemic shock who already had an invasive arterial blood pressure being recorded. There's 20 sequential patients. What they did find is that as we already sort of know, your radial disappears first, your femoral then disappears, and then your carotid as you become more hypotensive.
Right.
The interesting thing they found, though, is that in patients that had radial, femoral, and carotid pulse present, 83% of them had a systolic blood pressure less than 80, the mean of 70.
Right.
Those that only had femoral and carotid pulses, 83% had a blood pressure less than 70, so 64, and carotid pulse only, none of them had a blood pressure greater than 60.
And looking at that graph you showed us, there's a big range. So if you've got a radial pulse, your blood pressure could be as low as 50 systolic.
Absolutely.
Okay, Dave, so in that little study you showed us there's a big individual variation between the blood pressure that is associated with a radial pulse. What I'm interested in now is, despite that, is it safe to have a blood pressure equivalent to a radial pulse? Bruns et al. From the Journal of Trauma in 2008 is the next study off the rank, Dave.
Yeah, so this is a retrospective analysis of a level 1 trauma centre, 16,000 patients with a mean age of about 36 and 81% had blunt injury. What they found is that your pre-hospital systolic blood pressure strongly correlated with your systolic blood pressure in the ED. Mm-hmm. But more alarmingly, the risk of death increased sharply when your pre-hospital systolic blood pressure dropped below 110 millimetres of mercury, with nearly 1 in 10 or 8% dying in the emergency department and 1 in 6 dying eventually.
Okay, so Dave, that's not too dissimilar from this big one I found from Eastridge et al. 2007. This is trauma registry data. Nearly 750,000 US blunt penetrating trauma patients with a clear association between systolic blood pressure and death. Mortality increases 5% for every 10 millimetre of mercury decrease from 110. So Dave, some of those other studies did include head-injured patients, so some of that should clearly account for mortality because we know the association between systolic blood pressure and head injury survival.
Yeah, so Hassel-Era in 2011, published in Resuscitation, looked at similar prospective data from adult trauma database, so 161 trauma centres, and these were patients that had a GCS of 15, so they excluded traumatic brain injury.
Right.
They used a systolic blood pressure less than 110 as the cutoff for hypertension, and controlled for other variables including age. I guess the most alarming thing is your mortality rates, irrespective of age, doubled at a systolic blood pressure less than 100, tripled at less than 90, and were 5 to 6-fold at 70. These patients were predominantly male and had a median age of about 51. So a good representation of probably what we see in Australia.
All right, so it's very clear, Dave, that it's not good to be hypotensive, and the new magic number here is around 110. So my question to you is hypotension always present if you are bleeding and you are sick from trauma? So you've got a paper for everything, Dave. This is Kasavin from Journal of Emergency Trauma and Shock, 2011.
Yeah, and this was a prospective chart review to look at whether, if you're actually bleeding, are you hypotensive? And this is kind of a neat study. What they looked at is they looked at patients that were coming into the emergency department and had CT and had angiography to determine whether they had bleeding. So patients that had blush at angiography were regarded to have ongoing bleeding.
Sure.
So they looked at 113 consecutive patients, and 47 of these had evidence of ongoing internal bleeding, predominantly liver or spleen were the major sources. Two groups were similar between them, and among the 47 patients with ongoing bleeding, only 7 patients had a systolic blood pressure lower than 90 millimetres of mercury. The thing I really like, which is startling in this, is that 53% of the patients, so that's 25 patients, had a systolic blood pressure higher than or equal to 120 millimetres of mercury.
Wow.
So, your initial systolic blood pressure is not a good predictor of the ongoing internal bleeding.
So this final study is by Parks et al. In American Journal of Surgery, and what they're doing is comparing base excess and systolic blood pressure in shock.
Yeah, quite cleverly too. So they looked through the trauma data bank, looked at over 1 million records, and found about 11% of patients had their base excess measured, plus a first systolic BP in the ED recorded. 82% of these were blunt trauma. What they did is they validated base excess as a predictor of mortality after accounting for mechanism of injury, the systolic blood pressure, age, GCS, and injury severity score. Then they went through and looked at what the relationship was between the base excess and the systolic blood pressure. Now, unfortunately, the systolic blood pressure correlated poorly with base deficit. The systolic blood pressure did not decrease to less than 90 until the base deficit was worse than minus 20.
Wow.
And that's with a mortality of 65% when your base excess is less than minus 20. So once again, systolic blood pressure less than 90 millimetres of mercury is a late marker of shock.
And really, if it was available to you, you could potentially track base deficit using blood gases to see how your patient is actually perfusing during a hypotensive episode. Is that correct?
Yeah, absolutely. So serial base excess measurements would give you a measure of your success of resuscitation.
Okay, Dave, so you've just proven that hypotension is a late marker. Not everyone who's bleeding is hypotensive. What we've got now is a set of obs from a patient who you have seen as part of your retrieval work. I think this is one of the best examples of observation trends in hypotensive trauma I've ever seen. Can you talk me through these numbers, please?
Yeah, so this is a patient with pure blunt trauma, high-speed blunt trauma, who is being hypotensively resuscitated. So you can see there they've got a consistent tachycardia sitting around between 100 and 108. Systolic blood pressure, as we work across, sits at sort of 90, gradually rises to 98. It's a brief dip to 82 and then right up to 144. If you look at the pulse pressure across here, you can see that it's progressively narrowing. So to the point where we've got a systolic of 82 and a diastolic of 60. Also, if you look at the map, overall there's a general trend down, except for that very last measurement, which is the thing that I guess I've learnt most from this particular patient.
All right, so that last measurement is just before you turn up to the ED with this patient. For a lot of us sitting in the emergency department, we receive a new trauma patient, Dave, and we go, what's the blood pressure? You say 144 on 55. That's reassuring. A lot of people would say, great, good blood pressure, excellent, things are going well. What happened next with this patient?
Yeah, so as we transferred them to the emergency table, he basically had a pulseless electrical activity arrest. So basically became pulseless at that point in time.
So you're saying that this person who'd been sitting around 90 to 100 systolic, their blood pressure spiked just before they arrested?
Exactly.
Was this predictable, do you think?
From what I know now, yes, very predictable. From what I knew then, no.
All right, let's find out more. If we're going to go graph heavy here, which is always a bit scary, 5 graphs in a row. What's this first one all about?
This is basically looking at blood loss and the intravascular volume replacement with transcapillary fluid. So your interstitial fluid moving into your intravascular space. And what it shows is as you bleed, you can bleed up to 70% of your blood volume which you will then replace with interstitial fluid before you reach the terminal phases of shock. So in the initial phases of bleeding, hemoglobin measurements are of no value, and at the end, adding more crystalloid to someone that's bled profoundly just dilutes you even further.
Right. All right, next graph looks a bit familiar from primary exam physiology days.
Yeah, so this is a great study that was done in 1944. So these are people donating blood in the war where sometimes they take up to 1,000 mils at a time. So you can perfectly see what happens when you lose a litre of blood. And this shows what we all normally notice. So you've got heart rate increase, your pulse pressure narrowing, and a slight increase in your systemic vascular resistance with the falling preload.
So this is mild to moderate blood loss, and it's sort of what we'd expect.
Exactly.
This graph, a bit unexpected, Dave. What's happening here?
Yeah, so this was named after the people who performed this study, the Barcroft-Edelholm depressor reflex. And basically at a certain right atrial pressure, the vagal reflex overrides the rise in heart rate. And so you get a drop in cardiac output by a fall in heart rate and a fall in your systemic vascular resistance. Also notice that your pulse pressure is narrowing and you've got a continuing decrease in preload. This is thought to be protective to stop you from continuing to bleed from that wound that you've got.
So this is lying on the jungle, proto-humans, just bitten by the tiger, waiting for your mates to come, save your life by not bleeding out, right?
Correct.
Okay. So Dave, this terminal sympathetic storm looks a little bit like we might have seen with that patient you showed us before, that set of obs with the sudden spike at the end before an arrest. Can you explain this one?
Yeah, and unfortunately I think we have all seen this and been falsely reassured. This is essentially what happens once you reach the terminal stages of shock. There's a final last catecholamine surge, which massively increases your heart rate, pushes up your systemic vascular resistance, and generally causes a rise in your arterial blood pressure despite you still having very narrow pulse pressure. And the end point of this is death.
So basically, we should be really worried when a hypotensive patient suddenly sort of spikes their heart rate and blood pressure. You're saying this is last-ditch survival reflex?
Yeah, absolutely.
Righto, so we doctors like to screw with things a bit. This graph's showing us the variation that might happen if we get involved, is that right?
Yeah, and I think this is the reality. So remember, this data was achieved from people lying quietly, bleeding, thinking they were doing an altruistic thing. The reality when you're bleeding profusely from a major blunt trauma is you've got pain, you're fearful, people are giving you opiates, and all these things will suppress that depressor reflex. So it's a much more complex picture. That terminal sympathetic storm is still there. You probably just don't see the degree of depression in that mid phases.
Right. So this is actually potentially the influenceable part of the response to bleeding curve. Is that right?
That's right, and it's that mid zone where our resuscitation has to happen, not the end zone.
Right. Righto. So we've got this heavily sympathetically activated young bloke. And I guess it's important to also know, Dave, is it correct that when you're heavily vasoconstricted, you have much less flow to your vital organs than you would be if you weren't vasoconstricted with the same blood pressure? Is that true to say?
Absolutely, and I think that's the confusing thing in hypotensive resuscitation. Hypotensive resuscitation, where you're not maximally vasoconstricted, is probably okay because you have good perfusion to your end organs. If you don't have that good perfusion, then you're slowly toasting those organs.
So that correlates back to that basic X study, is that correct?
Exactly. So you've got tissue hypoxia and rising acidosis.
So I've been a bit naughty here, Dave. I've got the old ATLS response to bleeding class of shock graph, and I've stuck a big dirty cross in it. Have I done the right thing, do you think?
Yeah, absolutely. I think this helps you conceptualise what happens as you lose more blood from a very much laboratory-based principle. But the reality of what that other data shows us is that it's far more complex, and people look much better than what they are right up until the end, which is not conveyed from this classes of shock at all.
Particularly with that pulse rate. I mean, it really is unexpected to get, these days, we never see people with pulse rates of more than 140, do we?
No, and most people in that terminal phases of shock, their blood pressure their heart rate before that will be in the region of 120, 125.
And even your bloke that you showed us, I mean, the heart rate the whole way through was 100 to 108, wasn't it?
Yeah, absolutely. And there's so many other reflexes that are suppressing your overall heart rate. It's simplistic to look at this chart and try and interpret bleeding from it.
Okay, Dave, so in summary, the individual response to major hemorrhage is variable. There are many factors playing a role. But the take-home message really is, if I pushed you off that snow cliff that we saw you on earlier and you fell to the bottom and broke your femur, I would really expect you to have a heart rate of around 100 and a blood pressure of probably over 110. And if I found you and your blood pressure was 90, I should be really worried that you've basically torn something very major and you're bleeding out. Is that right?
Absolutely. So a hypotensive trauma patient is about to die.
Sorry, mate. So we now know all about hypotension in trauma, and what I really want to know now is, what do I treat this guy with and when do I treat him? So that's an obvious segue into the next episode of TiCME Chat. How are we going to treat traumatic hypotension? David Lamond, it's been an absolute pleasure having you along today. Are you going to come back so we can have this next chat for next time?
I'd love to, Nick. Thank you for having me.